badass doctors! Today we have a 56-year-old man who comes to the emergency department complaining of chest discomfort. He describes the discomfort as a severe retrosternal pressure sensation that had awakened him from sleep 3 hours earlier. He previously had been well but has a medical history of hypercholesterolemia and a 40-pack-year history of smoking. On examination, he appears uncomfortable and diaphoretic with a heart rate of 116 beats per minute, blood pressure of 166/102, respiratory rate of 22 breaths per minute, and oxygen saturation of 96% on room air. Jugular venous pressure appears normal. Auscultation of the chest reveals clear lung fields, a regular rhythm with an S4 gallop, and no murmurs or rubs. A chest radiograph shows clear lungs and a normal cardiac silhouette. The electrocardiogram is shown on the right. Based on the case's presentation, what do you think is the most likely diagnosis? 15 seconds on the clock, good luck. I hope you think it has something to do with a heart attack. Specifically, an acute STEMI, ST segment elevation myocardial infarction. I wanted to switch things up and give y'all a chance to tackle the case. Okay, here are the breadcrumbs. He has risk factors for coronary atherosclerosis, such as being a man over the age of 45, having hypercholesterolemia, and a bad smoking habit. His duration of the chest pain lasting longer than 30 minutes and the description of the chest pain being described as retrosternal pressure all indicate cardiac ischemia. Then his cardiac examination reveals an S4 gallop, which may be seen with myocardial ischemia because of relative non-compliance of the ischemic heart, and his vitals reveal hypertension and tachycardia, as well as this guy being diaphoretic, which are all signs of sympathetic activation. Then lastly, his ECG shows giant positive T waves, which are the earlier indications of an acute MI. Before we jump into talking about myocardial infarction, let's back it up and talk about acute coronary syndrome.
If I back it up, is it fat enough? When I throw it back, is it fast enough?
Acute coronary syndrome is a spectrum of acute cardiac ischemia that's caused by a sudden in situ thrombosis at the site of a ruptured atherosclerotic plaque inside of a coronary artery. Here are the 3 types of coronary artery disease and the order from least scary to the most damaging. Unstable angina.
Her name is Alata for China.
Non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction. The location of the blockage, the length of time that blood flow has been blocked, and the amount of necrosis that has occurred determines the type of acute coronary syndrome. Unstable angina is chest pain that occurs more severely and frequently even at rest and lasting longer, being unable to find relief from nitroglycerin. This occurs if the occlusion is incomplete or if the thrombus undergoes spontaneous lysis. In contrast, chronic stable angina is usually a flow-limiting stenosis caused by a plaque that causes ischemia during exercise without acute thrombosis. Non-ST segment elevation myocardial infarction is a heart attack without the ST segment elevation and with elevated cardiac biomarkers. It may have other ECG findings such as ST segment depression or T-wave inversion. And lastly, the scarier and damaging one is ST segment elevation myocardial infarction, STEMI, which is a heart attack with the ST elevation of more than 0.1 millivolts in 2 or more contiguous leads and elevated cardiac biomarkers. This occurs if there's a complete occlusion for more than 30 minutes. Myocardial infarction, MI, is commonly known as a heart attack. This is a coagulative necrosis of cardiac muscles due to prolonged ischemia that leads to an infarction. It's considered to be an acute MI if it's anywhere between 6 hours to 7 days after the onset of an MI. It's considered a reinfarction if it's an acute MI occurring within 28 days of an incident or recurrent MI. And it's then considered a recurrent MI if it's an MI occurring 28 days after an incident MI. The risk factors for myocardial infarction include men aged 45 or older and women ages 55 and older, having severe coronary artery disease, Having poor lifestyle choices like tobacco smoking, alcohol abuse, sedentary lifestyle, or doing little to no exercise. Having other comorbidities like hypertension, hyperlipidemia, hypercholesterolemia, hyperhomocystinemia, obesity, diabetes, or metabolic syndrome. Eating foods that are low in nutrients and high in kilocalories. Foods that are high in saturated fats, and foods that are high in trans fatty acids. So examples of high saturated fat content are fatty meats, chicken skin, processed or cured meats like salami, sausages, pepperoni, chorizo, pancetta, and bacon. Whole fat dairy products like milk, butter, cheese, cream, whipped cream, ice cream, chocolate, lard, and tropical oils like coconut and palm oil and dried coconut flakes. Examples of foods that are high in trans fatty acids are crackers, cakes, popcorn, coffee creamer, vegetable shortenings, margarine, refrigerator dough products, ready-to-use frosting, frozen pies, frozen pizzas, pastries, pie crust, fried chicken and biscuits, french fries, and desserts. Other risk factors include using illicit drugs like cocaine and amphetamines, having high mercury exposure, having chronic stress, having a history of preeclampsia, or having an autoimmune condition like rheumatoid arthritis or lupus. The diagnosis of acute MI is made by finding at least two of the following three features: typical chest pain persisting for more than 30 minutes, typical ECG findings, and elevated cardiac biomarker levels. Because of the urgency in initiating treatment, diagnosis often rests upon the clinical history and the ECG findings, while determination of cardiac biomarker levels is pending. During the clinical history intake, chest pain is the cardinal feature of MI. It's typically located in the retrosternal, substernal, or in the epigastrium region and is usually described as pressure, heavy, sharp, or squeezing, aching, crushing, or burning pain that lasts for more than 30 minutes and sometimes radiates to the jaw, neck, back, shoulder, or down the left arm. This chest pain is often accompanied by a sense of impending doom, nausea and vomiting, dyspnea, and diaphoresis. Although chest pain is the main feature of MI, the exception comes with diabetic patients, people over age 70, and some women who experience the unusual asymptomatic presentation called a silent MI, which tend to be more vague symptoms like unusual fatigue or weakness, sleep disturbances, dyspnea, indigestion, pallor, lightheadedness, dizziness, syncope, anxiety, pulmonary edema, or ventricular arrhythmias. Let's say we have a patient with chronic stable angina. The rule of thumb is if the patient doesn't find relief after taking nitroglycerin and it's been 5 minutes, it's time to call 911 to get emergency help. If symptoms are much improved by 1 dose of nitroglycerin, then they may repeat the dose every 5 minutes for up to 3 tablets over 15 minutes. But if they still have angina after taking 3 doses of nitroglycerin, then they should call 911. In terms of looking for signs of MI, there are no specific physical findings in a patient with acute MI. Many patients will be anxious and diaphoretic. Your vitals may show a tachycardic or irregular heart rate, increased respiratory rate, and the blood pressure may be elevated initially as it's trying to compensate, but hypotension and cardiogenic shock can be seen with right ventricular MI or severe left ventricular dysfunction. Signs of acute onset heart failure, including crackles in the lungs and signs of increased jugular venous pressure, may also be present. Cardiac auscultation may reveal an S4 gallop reflecting myocardial noncompliance due to ischemia, or an S3 gallop indicating severe systolic dysfunction. Or a new apical systolic murmur of mitral regurgitation caused by an ischemic papillary muscle dysfunction. During the initial evaluation, one must consider and exclude other diagnoses that typically present with chest pain, but would be worsened by the anticoagulation or thrombolysis usually used to treat acute MI. For example, aortic dissection often presents with unequal pulses or blood pressures in the arms, a new murmur of aortic insufficiency, or a widened mediastinum on chest X-ray film. Another example would be for acute pericarditis. It often presents with chest pain and a pericardial friction rub, but the ECG findings show diffuse ST segment elevation rather than those limited to a vascular territory. The electrocardiogram is often critical in diagnosing acute MI and guiding therapy. A series of ECG changes reflect the evolution of the infarction. First, the earliest changes are tau positive hyperacute T waves in the ischemic vascular territory. This is followed by elevation of the ST segments, which are myocardial injury patterns. Over hours to days, T wave inversion frequently develops. Finally, diminished R wave amplitude or Q waves occur, representing significant myocardial necrosis and replacement by scar tissue, and they are what one seeks to prevent in treating the acute MI. Sometimes when acute ischemia is limited to the subendocardium, ST segment depression, rather than ST segment elevation, develops. ST segment elevation is typical of acute transmural ischemia, that is, a greater degree of myocardial involvement than in non-STEMI. From the ECG, we can localize the ischemia related to a vascular territory supplied by one of the three major coronary arteries. As a general rule, leads 2, 3, and AVF corresponds to the inferior surface of the heart supplied by the right coronary artery. Leads V1 to V4 corresponds to the anterior surface supplied by the left anterior descending coronary artery. And leads 1, AVL, V5, and V6 correspond to the lateral surface supplied by the left circumflex coronary artery. Certain proteins referred to as cardiac biomarkers are released into the blood from necrotic heart muscle after an acute MI. Creatine phosphokinase level rises within 4 to 8 hours and returns to normal by 48 to 72 hours. Creatine phosphokinase is found in skeletal muscle and other tissues, but the creatine kinase myocardial band, CKMB, isoenzyme is not found in significant amounts outside of heart muscles, so elevation of this fraction is more specific for myocardial injury. Cardiac-specific troponin I and cardiac-specific troponin T are more specific to heart muscles and are the preferred markers of myocardial injury. These protein levels rise approximately from 3 to 5 hours after infarct. Cardiac-specific troponin I levels may remain elevated for 7 to 10 days, and cardiac-specific troponin T levels for 10 to 14 days. They are very sensitive and fairly specific indicators of myocardial injury, and their levels may be elevated with even small amounts of myocardial necrosis. Generally, 2 sets of normal troponin levels, 6 to 8 hours apart, exclude MI. On a side note for you docs with your own private practices, if this patient is in your private practice and you think he's had an acute MI or is having one, then you should call 911 without delay and do some early intervention to limit the damage. I like to remember this mnemonic MONA: morphine, oxygen, nitroglycerin, and aspirin, although you wouldn't give it in this particular order. After you call 911 for EMS to arrive, and while you're waiting, try your best to keep the patient calm, loosen up any tight clothing, and by all means, as doctors, always check yourself and keep your cool. If the patient becomes unconscious and unresponsive, be prepared to begin CPR. And have a defibrillator nearby to save their life in case if they go into cardiac arrest. If available, administer oxygen, which is the O, at 2 to 4 liters per minute via nasal prongs or face masks to increase oxygen delivery. Be sure to give a chewable immediate release aspirin, there's the A, that's dosed between 162 to 325 milligrams to increase survival likelihood and prevent further thrombosis. Give sublingual nitroglycerin, there's the N, to decrease wall tension and myocardial oxygen demand. And once the paramedics arrive, be sure to tell them what you had administered so far, and most likely they'll give IV morphine, there's the M, en route to the emergency department to help with anginal pain, and may give antiemetics concurrently to minimize nausea. It's so important that you don't allow the patient to drive themselves, because paramedics have the advantage of monitoring blood pressure and heart rhythm to forestall complications as they speed the patient to the ER. And it's just silly to have a person who's having a heart attack to be driving themselves and putting others in harm. The first hour after the onset of a heart attack is called the golden hour.
That's my golden hour.
This is a window of opportunity that impacts a patient's survival and quality of life following a heart attack. You'll probably hear the saying that goes, time is muscle, which comes from time is myocardium, meaning that the earlier you can get to opening an artery, the better it is, because myocardium can be salvaged only before it is irreversibly injured. This is because the heart muscle starts to die within 80 to 90 minutes after it stops getting blood, and within 6 hours, almost all the affected parts of the heart could be irreversibly damaged. So the faster the normal blood flow is reestablished, the lesser would be the damage to the heart. So once an acute MI has been diagnosed based on clinical history, ECG findings, or cardiac biomarker levels, it's recommended to give 325 milligrams of chewable aspirin, 180 milligrams of ticagrelor, or 600 milligrams of clopidogrel, and after obtaining IV access, we would give intravenous unfractionated heparin with a bolus dose of 60 units per kilogram to a max of 4,000 units, and then an infusion dose of 12 units per kilogram per hour to a max of 1,000 units per hour. To limit infarct size, beta blockers are used to decrease myocardial oxygen demand, and nitrates such as nitroglycerin are given to increase coronary blood flow. Morphine may be given to reduce pain and the consequent tachycardia, and patients are placed on supplemental oxygen. All of these therapies appear to reduce mortality in patients with acute MI. Next, we need to assess which coronary reperfusion therapy he is a candidate for between mechanical reperfusion such as primary PCI, percutaneous coronary intervention, and pharmacologic reperfusion such as fibrinolytic or thrombolytic therapy. Between the two, primary PCI rather than fibrinolysis is the current preferred method of choice for acute STEMI, as it is more effective than fibrinolysis in opening occluded arteries and is associated with better clinical outcomes. PCI, formerly known as angioplasty with stent, is a non-surgical procedure that uses a catheter to place a stent to open blood vessels in the heart and has been narrowed by atherosclerosis. It has been shown in multiple trials that PCI provides a greater survival benefit than thrombolysis and has a lower risk for serious hemorrhage as seen in thrombolytic therapy. If patients with an acute STEMI present within 2 to 3 hours of symptom onset and receive PCI ideally within 90 minutes, this is what we call door to balloon time, which is the time it takes when the patient arrives at the ED and receives treatment in the cath lab. Then PCI is the recommended reperfusion therapy. PCI is the preferred method of treatment for those who have a clear contraindication for thrombolytics, such as recent major surgery, active internal bleeding, or suspected aortic dissection, severe hypertension, or a prior history of hemorrhagic stroke, or for those who are hypotensive or in cardiogenic shock or have refractory ventricular arrhythmia or a large infarct size. Current recommendations from the American Heart Association and the American College of Cardiology is that primary PCI is the choice of method for STEMI patients. However, if primary PCI is not readily available as it may not be provided by the hospital, or if an interventional cardiologist is not available to perform the procedure in a timely manner, then fibrinolytic agents is the way to go. Fibrinolysis is preferred for patients who cannot make it to the cath lab within the first 120 minutes. The goal for timely fibrinolysis, aka door to needle time, is within 30 minutes. The best fibrinolytic agent is tenecteplase, TNK-TPA, which is the current drug of choice for current MI as a genetically engineered multiple point mutant of recombinant tissue type plasminogen activator because it has a long plasma half-life and is 14 times more fibrin-specific than streptokinase. If fibrinolytic therapy has been chosen as the primary reperfusion strategy, most patients should receive subsequent angiography and possible PCI of the infarcted artery. The third option is CABG, coronary artery bypass grafting, which is a mechanical reperfusion strategy for STEMI. This doesn't happen very often, but for patients who do need it, they are patients who are very sick and had an unsuccessful or complicated PCI, or they present with STEMI and continue to have recurrent cardiogenic shock or ischemia. Mortality in acute MI usually is a result of ventricular arrhythmias like VTAC and VFib, or myocardial pump failure and resultant cardiogenic shock, sustained ventricular tachycardia lasting longer than 30 seconds, and ventricular fibrillation are life-threatening because they prevent coordinated ventricular contraction and often lead to pulselessness and cardiovascular collapse. They must be treated with a defibrillator followed by an IV fusion of an antiarrhythmic agent like amiodarone. Any electrolyte deficiencies like hypokalemia or hypomagnesemia should be corrected as they can potentiate ventricular arrhythmias. Other frequent rhythm disturbances are bradyarrhythmias. Sinus bradycardia is frequently seen in inferior MI because the right coronary artery supplies the SA node, but the condition generally requires no treatment unless it causes hypotension. If the heart rate is slow enough to cause cardiac output and blood pressure to fall, IV atropine usually is administered. When symptomatic bradycardia such as third-degree AV block develop, they may be treated with external pacing but can require placement of a temporary transvenous pacemaker if the patient is in cardiogenic shock from a complete heart block. Patients in persistent complete heart block will require placement of a permanent pacemaker. Cardiogenic shock in acute MI usually is the most severe form of left ventricular pump failure, manifested by end-organ hypoperfusion. It's diagnosed when the patient has hypotension with systolic arterial pressure less than 80 millimeters of mercury, markedly reduced cardiac index less than 1.8 liters per minute per meter squared, and elevated left ventricular filling pressure. Clinically, such patients appear hypotensive with cold extremities because of peripheral vasoconstriction, pulmonary edema, and elevated jugular venous pressure, reflecting high left and right-sided filling pressures. Supportive treatment includes hemodynamic monitoring, adequate ventilation and oxygenation, and blood pressure support with vasopressors such as dobutamine and dopamine. These patients also may require mechanical assistance to augment blood pressure while providing afterload reduction using intra-aortic balloon counterpulsation. Cardiogenic shock may require urgent revascularization with primary PCI or coronary artery bypass surgery. The goal is to identify patients who are at high risk for subsequent cardiac events and who might benefit from revascularization. The initial evaluation involves submaximal exercise stress testing in stable patients before they get discharged from the hospital to detect any residual ischemia and ventricular ectopy and to provide a guideline for exercise in the early recovery period. The next thing to evaluate is left ventricular systolic function using an echocardiogram because post-STEMI patients with left ventricular dysfunction, such as a left ventricular ejection fraction of less than 40%, are at increased risk for sudden cardiac death from ventricular arrhythmias and may benefit from placement of an implantable cardioverter defibrillator. High-risk patients include those with impaired systolic function, large areas of ischemic myocardium on stress testing, or post-infarction angina, or ventricular ectopy who might benefit from coronary angiography to evaluate for revascularization. PCI can be performed to reduce anginal symptoms, and coronary artery bypass surgery should be considered for patients with multivessel atherosclerotic stenosis and impaired systolic function to reduce symptoms and prolong survival. The major goal of medical therapy is to prevent any cardiac events, whether they're fatal or non-fatal myocardial infarctions. By far the best thing a smoking patient can do is to stop smoking. Quitting tobacco can reduce the risk of fatal or non-fatal cardiac events by more than 50%, more than any other medical or surgical therapy available. A number of other therapies reduce the risk of recurrent cardiovascular events and prolong survival in patients with coronary artery disease. These are antiplatelet agents such as aspirin and clopidogrel can reduce the risk of thrombus formation. Beta blockers can reduce myocardial oxygen demand and may help suppress ventricular arrhythmias. And cholesterol-lowering agents such as statins reduce the number of coronary events and prolong survival. Patients with established coronary artery disease should have a low-density lipoprotein cholesterol level, less than 70 milligrams per deciliter. ACE inhibitors are recommended for all patients after STEMI, especially for patients with impaired systolic function with an ejection fraction less than 40%, diabetes, or hypertension.
Phew, that's a wrap on STEMI. All right, doctors, this is Dr. Sola signing off. See you next time. Mwah!
If I speed it up, can you handle that?